to know about the basics of retinopathy of prematurity. So the slides are not coming. So you need to know the normal retinal vasculature development. So it starts developing from the disc to the periphery by two processes, which is vasculogenesis and angiogenesis. When babies are born, most of them would have a temporal avascular peripheral retina. You see that it usually develops by 39 to 41 weeks. So what happens in utero? The retina matures first ahead of the vasculature. This cause requires a lot of oxygen. There is an increase in oxygen demand. So there is an increase in the VEGF there. This VEGF actually drives the vessels to grow from posterior to anterior. What happens when the baby is born preterm? The retinal vasculature is not developed and the baby is exposed from an oxygen saturation of 30 to 40 to a saturation of 90 to 99%. So what happens? There is a hyperoxic stage. So these are the phases of ROP. So when there is a hyperoxia, naturally there is a reduction in the VEGF requirement and there is a compensatory vasoconstriction. So, but the retina continues to mature and the requirement for oxygen increases. So at this stage, you see that VEGF is low and there is a vasoconstriction. This leads to a stage of hypoxia. When there is a hypoxia, then again the VEGF level would rise. But as a baby is growing, then you see that the insulin growth factor levels also naturally goes up. So when there is an interplay between these factors, then the vasculature goes into a proliferative stage. So you need to remember these two phases of ROP. There is an initial hyperoxia, there is a next hypoxia level, which leads to the proliferative phase of ROP. So that is the reason why you don't screen the babies immediately after birth. You wait for that proliferative stage to develop to see whether the ROP is coming. So the peak incidence is between 32 to 34 weeks. And as I mentioned, any baby who is born less than 34 weeks, easy to remember, screen every baby at 30 days of birth. And if the gestational age is less than 28, screen the baby at 20 days of birth. And there is already a neonatal forum guidelines for screening in India. All babies who are born less than 34 weeks of gestational age or less than 2,000 grams of birth weight should be screened, and any babies with any other risk factors as per the guidelines should be screened. Why is it important to screen? Because 50% of these babies can develop a sight-threatening retinopathy of prematurity, which if we screen and treat can prevent a lifelong blindness. What are the ways to screen? Ophthalmologists can directly use an indirect ophthalmoscope and screen the babies. Now we have an alternative. You can use a fundus camera imaging like a red cam or a Forus camera and send the images and can do a tele-ROP screening also. And when you go for a screening, you should have all these equipments. Indirect ophthalmoscope, a 28D or a 20D lens. You should have an ROP card to document the findings and to give the babies as a reminder to come back for a checkup. And if needed for a laser, you should have a laser indirect ophthalmoscope and a speculum intender and the topical dilating drops and anesthetic drop. Before going to the examination, you should collect the details regarding the baby, especially the most important birth weight, gestational age, any maternal risk factors if there are there, or any fetal risk factors. Then you have to wrap the baby to prevent any hypothermia. Dilate the baby with the 2.5% phenylephrine. It should not be more than that. And the drops should be put 2 times 15 minutes apart. And you have to put topical anesthesia. And also you can give some sucrose in a gauze to calm down the baby. After putting the topical anesthesia, you have to put a speculum and a depressor. Now, before going to the fundus, you have to see, using a 20D itself, you can look at the anterior segment. Look for what is the extent of pupil dilatation. If you see a well-dilated pupil, then you should be happy. If you don't see that, if a non-dilating pupil, always look at the peripupil rim, look for any neovascularization of the iris. Also look for any persistent pupillary membrane, and you should not get confused between these two. Also associated, look for any corneal abnormalities or any vitreous haze and cataract. Now documenting the fundus is as per the ICROP classification, which came up in 1984 and which evolved with time. And the recent one is ICROP 3, which came out in 2021. All of you should read about this modification. So the ROP should be documented. First, the zone. The zone 1 is with disc as the center, radius which is double the distance between the disc and the fovea. This is zone 1. Zone 2 is a circle which is drawn tangential to the nasal aura. So if you see a baby with the vascularization complete till aura, then it fits into zone 2. And the peripheral temporal remaining one is the zone 3. And in the recent modification, you can see that the zone 2, the 2 disc diameter away from zone 1 is called zone 2 posterior. This is to document for that. And sometimes you will see that the vessels might have grown till the zone 2, but you see a small term of extension to the zone 1 which is avascular. Then you should document it as zone 1. Even though the rest of the vasculature is in zone 2, it is zone 1 secondary to the notch. So this is a modification which has come in ICROP 3. And now depending upon the stage 1 is just a demarcation line. If you see a little volume to that, it is stage 2, which is a ridge. If you see that it is lifting to the vitreous, then it is stage 3. And when you have a retinal detachment, and if it is not involving the fovea, it is stage 4A. If it comes to involve the macula, it is stage 4B. And again, when there is a total detachment, it is stage 5. Recent classification have again subdivided stage 5. If you can see the disc, then it is stage 5A. If you cannot see the disc, that means the posterior is closed, then it is stage 5B. Along with this, if you see any abnormalities in the anterior segment, like a corneal opacity or any secondary glaucoma, then it goes to stage 5C. And one very important thing which you should look is plus disease, which as I mentioned, it is the iris neovascularization. In the posterior pole, look for vessel dilatation like this. So if these are there, then that is the plus disease. And another addition which came up later is aggressive posterior ROP, which means like you don't see that classically described stages over here. You see the loop like a network of vessels all around. You don't see the stage 1 demarcation line or anything. And the reason addition to this is you don't use the word posterior, because this kind earlier it used to be in very low birth babies and it used to be in the posterior zone 1. But now we do see this in bigger babies and even beyond the posterior one. So that now it is called aggressive ROP only, not aggressive posterior ROP. And you might see a hybrid ROP where you see in some area there will be collaterals and some area there will be stage disease. This is called a hybrid ROP. Now coming to management. So there is type 1 and type 2. Whenever you see a type 1 ROP, what is type 1 ROP? In any zone 1 or zone 2, if you see any plus, that is treat and type 1. And in addition, if in zone 1, if you see stage 3, without any plus, again that is type 1. So any plus, treat, type 1. Other than that, zone 1, stage 3, no plus, treat. So easy to remember. Rest all babies you need to follow. Coming to treatment. So the culprit is avascular retina and we told it is a VEGF. So you need to tackle these two. So the earliest one was cryo ROP. Cryo, they told, treat the baby when the disease reached threshold, and it led to anatomical outcome. Then came ET ROP. Don't wait till threshold. Treat early. That is early treatment. Treat with what? Laser. And it led to both anatomical and visual outcome. Now, this is still the gold standard treatment, that is laser treatment. So as I mentioned, treat type 1 ROP with laser. Now, which laser to use? Diode is the preferred one. Why? Because 532, in case the baby has a neovascularization of iris or a persistent pupillary membrane, the wavelength absorbs hemoglobin at that level and it might cause some anterior segment ischemia or iris sector. But if you don't have, still you can use a 532 laser. So both the lasers can be used. Now, the burns should be confluent, starting from the edge of the posterior to the ora serrata, and it should be confluent burns. If there is a non-regression, there is an option to treat even posterior to the ridge also. So it should be confluent burns. Now we have cryo, laser, and we need anti-VEGF. Why? Because laser and cryo will take some time for it to act, and now we do have more and more posterior disease. When you ablate, you get more of field loss. So you want to preserve posterior retina as much as possible, and VEGF acts faster. So that is why we use anti-VEGF. So in which cases, don't use in type 2, don't use in zone 2, it is in zone 1, AP-ROP or a half zone ROP. And which are the anti-VEGF? Bevacizumab, ranibizumab. And the only FDA approved drug is aflibercept as of now. So this is the difference. So anti-VEGF, it is easy to administer and it acts rapidly, but you need to have a longer follow-up for these babies because recurrence can happen in higher in this anti-VEGF group. Laser, it takes longer time. So this is a safer ROP which you need to know about it, the protocol for giving anti-VEGF injection. You can go through that. So what do you look after treating these babies? Look for regression. What? Reduction in the plus, reduced vascular dilatation, involution, and better pupillary dilatation. So after treatment, if you see the next day the pupil is really dilating well, then it is good. So this is what you should look. And this is another modification which have come in the regression pattern with what it has regressed. Okay, whether it is complete or incomplete. And with more and more of use of anti-VEGF, you see more and more babies following up with extensive peripheral avascular retina. And again, reactivation, you have to mention to what stage the baby has been reactivated, whether it is stage 2 or stage 3. And when to stop? When the retina is completely vascularized or the ROP has regressed, and you need to follow up these babies on a regular basis. So with laser, you need to see the baby at 1 week, 2 weeks, and then 12 weeks, and then follow up 6 months. With anti-VEGF, you need to see the baby after 24 to 48 hours, and you need a longer follow-up with anti-VEGF. And don't give the baby anti-VEGF when the baby has reached almost like 39, 40 weeks, or if you have already seen that there is a fibrovascular proliferation, because it can lead to a complication which is called crunch ROP. And you should document if any late complications like late retinal detachment, peripheral avascular retina, any of these things. Always remember, because as you now understood the pathology, that there is a time period or a window period for this disease. So you need to catch the babies on time. And this is at least and if you treat the babies on time, 85% of the babies, the vision would be saved. And this is the guidelines. You should read, everybody should read this article by Shukla. Okay, thank you.